Hey guys, good evening. Let's enjoy the chest radiographs with Dr. Y. I'm Dr. Y, chest radiologist, medical professor working in South Korea. Today's topic is lung cancer, usual features, everyday features, the common features of lung cancer, session 18. Before entering session 18, let's review the session 17, small cell lung cancer. 1. Cigarette is my amigo, my friend. 2. Although cell is small, the tumor is usually large. 3. Stage is commonly advanced. Small cell lung cancer's stage is usually advanced. 4. Unfortunately, small cell lung cancer returns at some time. 18. Common features, usual features of lung cancer at staging. A. I have told you before in the previous session that lung cancer is not possible to be differentiated from other subtypes on radiographs. And B, also I told you like this, there are a few generic features depending on location according to subtypes. These A and B is absolutely contradictory. A is not possible to differentiate the subtypes. B is possible to differentiate the subtypes. What's wrong? What happened? The answer is C. Usually, they are diagnosed late after local invasion and distant metastasis, so there is little chance for them is lung cancer to show their generic features according to their cell type. I'll let you know another terrible statistics about lung cancer. 1. 5-year survival rate of lung cancer is only 18.6%. 2. 5-year survival rate is 56% when localized within the lung. And 3. Only 16% of the patients are diagnosed early. In other words, more than 80% are diagnosed late diagnosis. And 4. The patient with distant tumors spread to other organs not within lung has a 5-year survival rate of only 5%. And number 5, more than 50% of the patients, lung cancer patients, die within 1 year. Very sorry. The 9 cases of the lung cancer patients, which I will show you now, will show you the usual everyday phases of lung cancer. 1. 2 squamous cell carcinoma, 3 adenocarcinoma, 2 small cell lung cancer, 1 large cell lung cancer, and 1 poorly differentiated lung cancer, which we do not know from which cell they originated. 2. There are 7 advanced stages, that means not operable, and 2 patients with a localized stage operable. Let's see the first case. What do we see? His lung is not looking good. Emphysema here, interstitial lung disease here. Right upper lobe shows many masses or nodules and poor thickening, paratracheal bulging, highlight elevation, highlight increased opacity, right pleural effusion, non-visualization of right diaphragm may be phrenic nerve palsy. This is right upper lobe lung cancer with pleural metastasis and many lymph node metastasis. And let's see the axial contrast enhanced CT. This is right upper lobe mass, more than 5 cm, about here, with pleural invasion. And bilateral mediastinal lymph node enlargement. That means N3 staging in upper staging. And pleural effusion. This probably will be metastatic pleural effusion, stage of M1A. And this is another enhancing nodule in muscle. This is muscle metastasis, M1C staging. So this is advanced staging. At a lower level, we find another pleural nodules, pleural effusion, and rib and pleural metastasis, rib destruction of metastasis. And in this MIP PET-CT image, not only right upper lobe lung cancer, many pleural nodules, many rib metastasis. Yes, so this patient is squamous cell carcinoma of right upper lobe, T3, N3, M1C, TNM staging, advanced, late diagnosis. This is the second case of squamous cell carcinoma. We remember this patient. We have seen him before. Yes, this is left main bronchus. In the middle of the bronchus, there is a block. Something is blocking here, and left total collapse. Yes, in the coronal CT, there is a tumor blocking here, and this is all tumor, more than 7 cm, and all collapse of left lung, diaphragm elevation, and pleural effusion around the collapse. This is the usual shape of lung cancer. This coronal MIP PET-CT shows almost everything. Large mass with lymph nodes, more than 7 cm. This is squamous cell carcinoma at left main bronchus, left total collapse, and T4 and 0 or something more than this, and M1A staging, advanced, not early staging, advanced stage, late staging, not operable. This is a third case of a relatively young woman. She is never smoker. What do we see? You got it? Yes, there is something conspicuous, maybe here or maybe not. Here, and other field looks okay. Let's look at the thin section CT of lung window setting. What do we see? This one, 2 cm ground glass nodule with part solid component. We usually measure solid components lengths in TNM staging. So T1A staging, less than 1 cm of solid portion. Yes, she is adenocarcinoma, part solid ground glass nodule, T1 staging. Is she lucky or not? She has lung cancer. That is very unlucky for her. But she has ground glass nodule of T1 staging. This is somewhat lucky for her. She's never smoker, so her lung is very nice, good for the operation. This is operable case, one of the lucky case of today's lung cancer patient. Let's look at another case of adenocarcinoma. Left hilum is abnormal, increased opacity with a deformed shape, normal pulmonary artery shape is gone, and there is another increased density over here. So these are all masses. And left diaphragm is elevated, possible phrenic nerve invasion. Let's see this axial contrast enhanced CT. Yes, more than 5 cm left upper lobe mass, broadly attached, invading mediastinum, and here is the phrenic nerve course, so possible invasion of phrenic nerve and several small mediastinal lymph nodes here. So lung cancer left upper lobe mediastinal invasion with ipsilateral lymph node enlargement, T4 and 2 at least. His brain MRI shows multiple enhancing metastatic nodules. This is edema around the tumor. Yes, multifocal brain metastasis. And PET-CT shows left hilar mass with conglomerated multiple mediastinal lymph node, contralateral lymph node enlargement, supraclavicular right, supraclavicular left lymph node enlargement, N3 staging, and multifocal brain metastasis. So adenocarcinoma of left upper lobe, T4, N3, M1C, far advanced staging of left upper lobe adenocarcinoma. This is the usual shape of lung cancer of everyday shape. It is famous for the brain tumor. What is the common tumor in the brain? Primary tumor or metastasis? Yes, metastasis. What is the number one metastatic tumor to brain? It is lung cancer. So, number one brain tumor is metastasis from lung cancer. On this chest radiograph, this old woman does not look so good. Total haziness of right side with cardiac shift to left side. What happened? Serious looking. On her axial enhanced CT, we see huge amount of right side pleural effusion compressing the mediastinum and heart to the left side. This is collapsed lower lobe. This is collapsed middle lobe with a central tumor here. Yes, middle lobe tumor with right massive pleural effusion. Let's look at her coronal CT. Massive pleural effusion compressing heart to the left side. Middle lobe collapsed, lung with internal tumor mass, collapsed lower lobe, collapsed upper lobe, and pleural nodule, pleural metastasis, pleural nodule. This means this is malignant pleural effusion. So M1A staging with collapse T3 staging. Let's look at the PET-CT image. Tumor mass with multiple heart uptakes, maybe lymph node, maybe pleural seeding. And on the left side, also there are several heart uptakes. This means distant metastasis. So her right middle lobe adenocarcinoma with T3 and 2 M1C staging, far advanced stage. Now let's begin the small cell lung cancer. Yes, we know this patient image. Yes, we have seen him before in the previous session. This is small cell lung cancer with lymphatic obstruction. Increased density, deformed normal anatomy, deformed mediastinal line, increased opacity, all are telling us this is the tumor, large tumor. With this coronal chest CT, the mass is almost same as on the chest radiographs, conglomerated left hilar and suprahilar mass. So it is staged as limited. It was mistakenly staged as limited stages, not extensive stage. But look at this PET-CT MIP image. Large, conglomerated, strong heart uptake of tumor mass here, and almost everywhere shows multifocal heart uptakes. Almost whole bodies showing us metastasis. So much tumor burden of small cell lung cancer. In TNM staging, this is T4 and 3 M1C staging, stage 4, terminal stage. This is another case of small cell lung cancer. What do we see? Let's enjoy the images. You got it? Right pretracheal stripe obliteration and tumor bulging over 3 or 4 centimeters. Is that all? No, more. Surely more. Bronchus intermedius is narrowed, compressed by the increased density, mass density under the bronchus intermedius. Mass is compressing, and right interlobar pulmonary artery is not in normal shape. Increased density, obliterated shape, deformed margin. Yes, so it can be imagined these are all tumors. Increased density here, not usual normal density. This is mass. This is mass. This is mass. What it looked like on the coronal CAT scan. This is the real shape on coronal enhanced CT. Conglomerated mass, bulky lymph node mass of small cell lung cancer. Let's look at the PET-CT. More than that, bigger than the CT image, because this is the summation image, not one plain image. Huge conglomerated heart uptake, separated nodule, separated lymph node, large supraclavicular lymph node. Yes. At first glance, this is limited stage. Yes, it's correct. Ipsilateral, one unilateral side means limited stage, but T4 and 3 staging, far advanced stage, small cell lung cancer. This is the everyday life findings of small cell lung cancer, usual shape. What about this chest radiograph? What do we see? Look at the left hilum, infrahilar portion, bulging mass with irregular margin, increased opacity, obliteration of a heart border, paraspinal line border, with a large pleural effusion, nodules here on left side, another 1.5 centimeter nodule in right upper lobe. Yes, an aortic knob is not good looking. Large mass here with metastasis to the lungs and malignant pleural effusion. I think so. Let's look at the coronal CT. Infrahilar mass with mediastinal invasion, large mass with pleural effusion, sure, malignant pleural effusion, and left adrenal mass, metastasis, and destroyed spine, and mass in the spleen, spleen metastasis. Left lower lobe mass with bone, adrenal, spleen metastasis with malignant pleural effusion at least, And let's look at the PET-CT. Left lower lobe mass with lymph node enlargement, right upper lobe metastasis, left upper lobe metastasis, multiple bone metastasis, spine, left adrenal, spleen metastasis. This is poorly differentiated cell, poorly differentiated tumor. We don't know which cell type is this. Very poorly differentiated. That means prognosis is not good and therapy is not good. Non-small cell lung cancer. T4, N2, M1C. Far advanced stage. This is the last case of this session. What do we see? How do you feel now? Very confident? Interesting about the chest radiograph, or very fearful, dreadful about the lung cancer? Okay. We see 2 cm nodule here in right lower lung zone. Is that all? Let's find out something more. How about his basal lung? Looking not good. Honeycomb lung. Chronic, prolonged smoking history. Yes, probably his lung is not good. SPN. Stage seems to be better than the other patients. After examination with contrast-enhanced chest CT, brain MRI, and this PET-CT, we concluded that he has only tumor cell here, T1 staging, no lymph node, no distant metastasis, so T1 M0, N0. Actually, he's unlucky because he has lung cancer, and unlucky because his cell type is large cell. But he's relatively lucky because his staging is so good, T1, N0, M0. So he was operated and still going good. But we are still some worrisome about him because his cell type. How do you feel now after review of chest radiographs? Every day's chest radiographic findings of lung cancer. Somewhat fearful, somewhat interesting. Okay, today's let's take home messages are: 1. Lung cancer is usually diagnosed late. Late diagnosis. That is big problem. 2. Avoidance is the best policy against lung cancer. 3. Rather than miracle medicine, development of miracle medicine against lung cancer, just don't smoke is our true goal. This is the answer for the last quiz. Ankylosing spondylitis. Are you correct? It is also called as bamboo spine. Congratulations! Quiz for the next session. What's in her soft tissue? Fine linear densities. Like, subscribe will be a big support to me. Thank you very much.